Hello everyone, I'm Preeti. Welcome to my channel, Dialogue with Doctors. In each episode, I engage in an extended discussion with distinguished doctors to discuss threadbare every aspect of a disease or disorder. I inaugurated my channel by discussing coronary artery disease. And in those discussions, we learned that diabetes is a major risk factor for developing heart disease. So in today's episode, we are going to be focusing on diabetes. Friends, the incidence of diabetes is increasing at a very rapid rate in India. So much so that nearly 16% of the adult population in urban India is developing diabetes. To make matters worse, the age of onset of diabetes is also coming down, which means that people are being diagnosed with diabetes at a much earlier age than ever before. I don't want to sound alarmist, but we seem to be in the midst of a diabetes epidemic. The world has anyway labeled India as the diabetic capital of the world. So in such a grim scenario, what can we do to prevent diabetes? Or if not prevent it altogether, what can we do to delay its onset or to deal with it effectively so that the adverse effects of diabetes on our other organs can be checked as soon as possible? In order to discuss all these issues, we are privileged to have with us Dr. Sanjay Kalra. Dr. Kalra is a renowned endocrinologist. He has been treating diabetes and various other endocrine disorders for the last several decades. He's a visiting professor of endocrinology at AIIMS Rishikesh and a consultant endocrinologist at Bharti Hospital, Karnal. Moreover, he's a distinctive presence on YouTube where he has uploaded innumerable talks and lectures on diabetes and various other health-related issues. So welcome, Dr. Kalra. Without further ado, let us plunge into the discussion. Let me pick Dr. Kalra's brains and let's get to know all about diabetes. Sir, before we go on to discuss the diagnosis and detection and treatment of diabetes, I think it would be better for us to understand the disease a little better so that we are better equipped to deal with it. So can you explain it to our viewers what exactly happens in diabetes?
When we use the word diabetes, we are referring to a very vast spectrum of disorders, vast spectrum of diseases. They have different causes. They have a different clinical presentation. The course, the natural history of the disease may differ, and the choice of treatment also differs. But in general, when we speak of diabetes, we are speaking of something known as diabetes mellitus. The word mellitus means sweet. And diabetes mellitus means a disorder in which there is sweet urine. So the definition itself is based upon sweetness, upon sugar. Within diabetes, there are different types of diabetes. We have the common ones are type 1, type 2, pancreatic, and gestational. But 95% of all our patients have type 2 diabetes. So allow me to focus on type 2 diabetes mellitus. So when we are speaking of diabetes, there can be many reasons why diabetes occurs, but there are two common reasons, two main ones. The first one is insulin deficiency, and the other one is insulin resistance. So what is insulin? It is a hormone. It is a hormone which is produced by the B cells or the beta cells of the pancreas. A hormone is a chemical substance which is secreted in very minute quantities, very small quantities, micrograms, nanograms, picograms, but it packs a powerful punch. So these hormones circulate in the blood and they go and attach themselves to various receptors. You imagine a key that is latching itself to various locks. When it opens these locks, the locks open, the doors open, and various chemical processes start. The poisons of the body are excreted from the body. The good things in the body are kept inside the body and they're able to enter the cells. So the cells get their growth, their sustenance from these hormones. Insulin is an anabolic hormone. What does anabolic mean? Anabolic means it is body building. It helps you build your body. So it allows glucose to be taken up into the cells so that the cells can use it. Now, in some people with diabetes, there will be insulin deficiency. There is no insulin. There is no key. So the locks won't open. If the locks won't open, the nutrients, the good things of the body are not going to enter the cells. They're not going to enter the organs like the liver, the muscle, the fat tissue. And therefore, the body will begin to lose weight, lose mass. This is insulin deficiency. But at the same time, there is another factor which is playing in the body in diabetes, that is insulin resistance. What does this mean? You imagine that we have the key, the pancreas is working well, producing insulin, but the locks are jammed. Maybe the locks have rusted. In some people, only the liver locks may rust, the liver receptors. In others, it may be the muscle and the adipose tissue as well. And you can have various permutations and combinations. So it is possible that you are in the middle of the ocean. There is water everywhere, but not a single drop to drink. That is insulin resistance. There is a lot of insulin around you, but it's not being put to use.
Okay.
And it is equally possible that you're in the middle of the desert, you're thirsty because there is no water to drink.
Right.
So both scenarios play out in diabetes.
Dr. Kalra, you explained really well the difference between insulin deficiency and insulin resistance, right? That and the analogies that you have used, the comparisons to being surrounded by water and yet not having any of it, I think really simplifies matters for our lay viewers to understand. I'll turn to my next question, which is that who can get diabetes? By that, I mean, who is at a greater risk of developing the disease? Can everyone get it? I mean, are there certain risk factors which make it more likely for certain people to develop the disease? Or is everyone equally vulnerable to developing the disease?
So anyone can develop diabetes. That would be the first statement. But certainly there are risk factors where we should be more careful. In most Indian languages, the word for the drum is dhol. So this is how we remember it. People who have darkening of skin, something known as acanthosis nigricans, black patches over the neck, over the elbow, they are at greater risk of diabetes. People with, so that was D. H is for high blood pressure, those with high blood pressure. O is for obesity, overweight, a disease known as OSA, obstructive sleep apnea, where there is a lot of snoring at night.
Right.
O is also for ovary. So women with PCO, polycystic ovary syndrome. L is for lipids, those with high cholesterol. L is also for liver, those with a fatty liver, in case you get an ultrasound done and it shows a fatty liver. So these are the people who are at greater risk of developing diabetes.
Right.
Apart from that, the main factor would be a family history. So if you have parents, if you have a sibling who has developed diabetes, especially diabetes at a young age, then you are at exceptionally high risk of developing the disease.
Sir, Dr. Kalra, you've explained these two kind of factors. One is, I think, the genes that we inherit from our parents and our ancestors, right? That's one factor. So if somebody in our family, even if a grandparent were to have diabetes and our parents were not to have diabetes, my question is, how does this interplay of nature and nurture kind of play out? Imagine that both the parents of an individual have diabetes, but the person adopts a healthy lifestyle, is active, eats healthy, keeps the weight under check. So would such a person be also at an equal risk of developing the disease because his parents have? Is it a kind of foregone conclusion for such a person? Can we say that our genes are our destiny then?
Our genes are our destiny. That is partly true, but we can build our own destiny. And in this particular case, our destiny is in our own hands, and it is in our feet more than in our hands. So yes, we do have a situation in India where most of us are genetically predisposed to diabetes. Let me explain the reason for that. You and I, Dr. Preeti, we are the first generation of independent India not to have experienced famine.
Right.
Even in the 1960s, there was famine in our country. So our ancestors, they evolved in such a way that, they were not sure whether in a particular season there would be famine or there would be feasting. Right. Think of them like the camels that you see in the Thar desert. So when the camel sees water, she drinks a lot of it because she is not sure whether she will get water tomorrow or not. Right. She stores a lot of water in her hump, and then that lasts for a month or 2 months. Similarly, what happened to our ancestors, whenever they would get a good crop, a good yield, they would eat a lot of food. They would store it in their adipose tissue in their fat in their bellies. And even if the next year was famine, they would still survive. They would get through it. So there were these cycles of famine and feasting which would balance each other out. Now, modern India has not experienced famine, which is a good thing. So every year we have feasting, feasting upon feasting upon feasting. That has converted an adaptive mechanism into a maladaptive one, into a disease producing situation. There is too much of storage of energy. You can imagine the Bhakra Dam, for example. It is meant to store water, to store energy. But if there is a landslide, if there is a cloud burst, if there is excessive rain, even the dam will not be able to manage all that water. And sometimes we do have unfortunate situations. So that's what's happening in the body. Now, regarding whether we can change things or not, yes, we can. We are predisposed to diabetes, that is correct. But it is in our hands and in our feet to postpone the onset of diabetes and thereby postpone the onset of complications of diabetes. So, with a few lifestyle changes, and we'll speak about that shortly, we can easily change our destiny.
So, but coming back to my question again, are our genes our destiny? I mean, you do say that you can delay the onset of diabetes, but it is kind of inevitable that a person in whose family history there is diabetes, both the parents have diabetes, or maybe the grandparents also have diabetes. So, however healthy a lifestyle such a person adopts, is it inevitable that such a person will at some stage develop diabetes?
That is true for one particular type of diabetes, which is known as MODY, MODY, maturity onset diabetes of the young. It is also true for a very, very rare disease known as mitochondrial diabetes. This is inherited from mothers, not from fathers. These are monogenic. That means a single gene is involved. These are monogenic forms of diabetes. So if the particular gene is absent or is defective, then you will get diabetes. But of course, maternally inherited mitochondrial diabetes is a severe disease. It is associated with deafness. But MODY is not all that severe. It's very mild. And then it is a foregone conclusion. But MODY would be present in maybe 0.1% of all Indians with diabetes.
Dr. Kalra, you mentioned that we are genetically susceptible. Are Indians, does their ethnicity make them more prone to diabetes, developing diabetes vis-a-vis other populations, maybe in the Western world and other Asian countries?
Yes, it does. So first of all, our genes. Then secondly, this environment that our ancestors grew up in and the adaptive mechanisms that they formed. Third, we have something known as normal weight obesity. So obesity is common in India. We can see that. We can see that everywhere. But even in people who are not obese, supposedly not obese, in those who have a normal body weight, you will find that they have more central fat, more abdominal fat. So their waist circumference is more. They have a tiny belly, both men and women. This also predisposes to diabetes. So this is true. As a country, as an ethnic group, irrespective of which part of the country we live in, we are all predisposed to diabetes. And now, Dr. Preeti, you can view that with despair, that there is nothing that can be done, that is our destiny. But we can also view it as a window of opportunity. We can view it as an opportunity to demonstrate our resilience, to demonstrate our ability to fight disease, to create our destiny.
Right. I really like the optimistic note that you have struck. And, you know, I didn't want to paint a grim scenario, but in my opening remarks, I did end up talking about the bad things and the early onset, etc. Anyway, my next question is about the fact that diabetes is a kind of painless condition. It's silent. It kind of creeps up on you. It's something, it's very insidious. I mean, is it possible for a person to have diabetes and not manifest any symptoms at all? Can one be asymptomatic and yet have diabetes?
This is actually the commonest presentation in more than half of us. In more than half of the people who live with diabetes, there will be initially no symptoms. Very few people will come in with a very dramatic kind of an onset, falling very sick, going to the bathroom 100 times a day, needing admission. That is very rare. It usually happens in type 1 diabetes. But let's talk again about these symptoms or complaints or concerns, and let's talk about the definition of health. Now, the World Health Organization defines health as a state of physical, mental, and social well-being. But we should add one more word to that, and that is a sustainable state, a state of sustainable physical, mental, and social well-being. So in the short term, there will be many patients who do not have any symptoms. First of all, then they will not get themselves tested. Second, even if they do, they will deny the disease. They will say that the machine is wrong. They will find fault in everything except themselves. Third, they will not accept therapy. But this is not sustainable. Diabetes is like a termite, it will eat you from within if you do not control it. So allow me, Dr. Devan, also to paraphrase my sentence. Diabetes is not a termite. Diabetes is not a killer. It is uncontrolled diabetes, which is a silent killer.
Right.
So if you're able to control it, you've won the war, you've won the battle.
Right.
But if you don't get treated, then that asymptomatic phase actually, it just creeps up on you from inside. And before you know it, you've got the complications.
Right. So, sir, I mean, the initial stage, one may be asymptomatic, not really manifest any symptoms, but maybe soon after, there might be some telltale signs which lay people may not really be aware about, and they may miss out. They may see those signs as innocuous, or they may not really attach any significance to those signs. So could you please tell our viewers a little bit about what kind of signs and symptoms to be vigilant about?
Let's take this in 3 buckets. Classic signs, signs or symptoms of complications, signs or symptoms of comorbid disease. That means other disease. So classic, complication, comorbid. We'll do it one by one. The classic symptoms are increased thirst, increased hunger, increased urination. Also, easy fatigability and being more prone to infections. Now, the problem here is that suppose I'm a 50-year-old lady and I begin to go to the bathroom once extra at night, twice extra, thrice extra. What will I do? I will speak to my friend. I'll speak to my sister-in-law, maybe my sister, and I'll tell her, I have this problem. I have to get up at night. And the answer usually is going to be, Didi, I also have to get up. I
also do the same thing, right?
Yeah. So
right.
Then you assume it's normal.
Right.
Supposing I am a 40-year-old gentleman, and earlier I used to run on the treadmill 20 minutes without getting tired. Now I get tired after 15 minutes.
Right.
Earlier I never had a common cold. Now I've caught a common cold 3 times in the past 6 months. I speak with my best friend and I tell him this is what is going on. He'll say, doesn't matter, you are not young anymore. You've crossed 40 now. Right. So the same thing is happening to me. Right. So society tends to normalize some of these symptoms.
Yes.
So that is one issue. These are the classic symptoms we should be aware of. The second is complications. So diabetes actually may present as heart disease, kidney disease, reduced vision, blurring of vision.
Right.
It may present as pain over the hands and feet,
right.
or numbness over the hands and feet. So these are the complications.
Right.
And comorbid means occurring along with something else. So diseases like hypertension, high cholesterol, liver disease, kidney disease, they can occur along with diabetes. And it might be that we just realize we've got diabetes when we see these symptoms.
Right. I think one of the doctors that I was listening to on YouTube happened to describe diabetes and all these other comorbid conditions as a 4-legged stool, right? That diabetes is like one of the legs of the stool. The other legs are hypertension and the deranged lipid profile and other things that you mentioned, right? So it doesn't really occur in isolation.
Very rarely. Usually there will be something else. It is rare to see diabetes in isolation. There will be something else or the other. Right. It can be thyroid, it can be other hormonal issues, and it can be the heart-related or the metabolic issues. Usually you will see something else or something or the other.
Right. I think sometimes, like when you talk to your neighbors or you talk to your friends or in your social circle, you discover that people go for, they go for testing for some other condition. And then they discover that, they are diabetic. So it's a kind of chance finding which occurs during investigations. It's kind routine of serendipitous kind of finding. So is that a common occurrence, Dr.
It is quite common. It is quite common, and we should actually be grateful for that. If you've got diabetes when you're asymptomatic, it means you've got it early. And it means we've got an opportunity to prevent the disease from progressing. There is a chance of getting it into remission. And certainly, we will be able to prevent complications. So if anybody is diagnosed to have diabetes without symptoms, without complaints, do not feel upset, do not feel sad, don't go into depression.
Right.
Feel happy, feel optimistic, and feel that you've got a chance to regain your health or to maintain your health.
Right. I really like the way in which you sound a reassuring note to all the viewers that the picture is not bleak or grim. Don't despair. That's the note that
there's lots we can do. Yeah, we just have to begin doing it. Yeah.
Right. Okay. So, Dr. Kalra, now I'll turn my attention to diagnosis and testing basically. First, I'll split that question into two parts. Or people who are not known diabetics, or people who are not diagnosed as diabetics. How frequently should they undergo testing? For diabetes, should it be a part of their annual health checkup? And at what age should they start undergoing a routine test for diabetes? And this is only for people who are not known diabetics.
Annual should be more than enough. Annual should be more than enough. And if you're above 30, there is no harm in actually getting a glucose done. So this is routine. But apart from that, there is something known as opportunistic testing. If there is an opportunity, let us say you are going to the lab and you're getting your blood group done for a driving license, you can tell the laboratory technician, why don't you do a glucose for me as well? Right. It's so economical, so cheap. Apart from this, if there is any sudden change in health status, which may be associated with a change in glucose levels. Let us take some examples. Suddenly, somebody develops tuberculosis. Right. That is associated with high glucose. Somebody has to take steroids for whatever reason. Right. That is associated with high glucose. Then you don't have to wait for 1 year to get your routine checkup done. You can get it done early. So if you anticipate or expect any change in glucose levels because of any change in overall health status or overall medication status, then we can test more frequently. Otherwise, once a year is more than enough in adults age 30 and above.
And sir, the second part of the question is about testing for people who are diagnosed as diabetics. So how frequently should they undergo testing? My second question is that I think they are advised to undergo testing once in 3 months from the lab. But is it advisable for them to undergo testing at home by using a glucometer? And how reliable are these glucometers?
The good glucometers available in the country are reliable. Whenever you buy a glucometer, number one, buy a good brand. Do not buy something that is made from a fly-by-night kind of a country. Ask the chemist if after-sales service is available or not. Check around if sticks are available or not. And if in your locality, sticks for that particular glucometer are available only at one chemist, that is a red herring. It means something is wrong somewhere. If you're in doubt, just go on the net and search. Right. And you will find the best brands telling you that they are good brands and telling you that they are available in India across the length and breadth of the country. Right. Now, regarding how frequently to check, there is something known as HbA1c, glycated hemoglobin, that should be done once in 3 months. Sometimes in some people, we get it done at 4 or 6 weekly intervals also. Okay. In pregnancy, for example.
Right.
Glucose monitoring varies from person to person. If someone is on an intensive insulin regimen in pregnancy, you might actually want 7 glucose tests every day. This is when you are really worried about the child, about the mother.
Right.
In others, if you are giving a drug like maybe metformin, SGLT2 inhibitors, which are not going to cause low glucose, you can check just once in a week or once in 2 weeks as well.
Right.
It will vary from patient to patient. It will vary upon the drug that is it will depend upon the drug that is being given.
Okay.
The risk of low glucose and the dangers of high or low glucose.
Right.
As an example, if it is an elderly lady, 70 years old, I am worried that if she gets low or high glucose,
right,
she may get into trouble. I will ask for more frequent monitoring.
Right.
But a 35-year-old gentleman who is otherwise healthy and taking a very mild kind of a tablet, I'm not too much worried about him. If the HbA1c is good, I'll say once in 15 days is fine for checking.
Okay. We understand that there is no one criteria, one size fits all. That doesn't work for testing. I mean, as you explained, in cases of pregnant women with maybe gestational diabetes who are being given insulin, then they need to test multiple times a day, etc. Right. So now I'll turn to my next question, Dr. Kalra. In the beginning, you talked about various types of diabetes. And I think as far as lay people are concerned, for instance, myself, I know only about type 1 and type 2 diabetes. And I've heard about gestational diabetes. So can you speak more in detail about type 1 and type 2 diabetes? And what exactly is the difference between these two types of diabetes?
Let's begin with type 1 diabetes. In type 1 diabetes, there is a destruction of the B cells or the beta cells in the pancreas. So if the B cells get destroyed, then there will be no insulin because it is the B cells or the beta cells which produce insulin. So there's no insulin. This is absolute insulin deficiency. So we will have to give insulin from outside. Injections are a must. Otherwise, the child or the adult will not survive. Type 1 diabetes usually occurs in children, but it can occur in adults as well. It can occur actually at any time of life, but it is most common in children and adolescents.
Okay.
In pancreatic diabetes, there's another disease. In that, there is destruction of the B cells and the A cells, the beta and the alpha cells. The alpha cells produce glucagon, the beta cells produce insulin. Glucagon and insulin balance each other out. The role of glucagon in the body is to prevent low glucose. It prevents low glucose. So in pancreatic diabetes, what happens is when the alpha cells are also destroyed, there is no glucagon. So the patient is at equal risk of high glucose because the insulin is not there, and at risk of low glucose because glucagon is not there. There can be pain in the abdomen, and there may be difficulty in absorbing food because the pancreas is the organ which absorbs a lot of our proteins and fats and carbohydrates through its enzymes. So here you have to give small doses of insulin, and you have to give a pancreatic enzyme replacement as well. Right. And you might have to give painkillers continuously to prevent the pain that is occurring in the pancreas. Both these are quite rare actually, type 1 and pancreatic. Pancreatic diabetes is more common in the lower socioeconomic status, in people who have gallstones, in people who drink a lot.
Okay.
Drink a lot of alcohol.
Right.
Type 2 diabetes is the most common in our country. This is a mixture of insulin resistance and insulin deficiency, like we explained. So right. Therefore, you have to give drugs which are insulin sensitizers. They sensitize those locks, those receptors, right, to respond to insulin. And you can also give drugs which secrete more insulin from the beta cell.
Right.
Initially, we give tablets. But as the disease progresses, the beta cells become weaker and weaker. And then sometimes we have to give insulin in type 2. Right. Within type 2, Dr. Devan, there is a disease known as diabesity. Okay. This is a portmanteau, a word that is a mixture of diabetes and obesity. This is becoming more and more common in our country. Okay. It is important to know about diabesity because our choice of drugs changes then. Then we use drugs which reduce glucose and also reduce body weight at the same time. Okay. Right? So that is common. And another one, which is of great public health importance, that is what you alluded to, gestational diabetes or right, pregnancy-related diabetes. Right. Now, what is happening is that 1 out of every 7 pregnant women in India has diabetes. It doesn't mean this is during pregnancy. Right. So we have to screen all of them whenever they come for their first antenatal checkup. That screening is done to rule out pre-existing diabetes because, you know, it can be asymptomatic, so you never know. Right. And then you screen around 20 weeks of pregnancy, around right, 5 to 6 months. That is done to rule out gestational diabetes. Right. In GDM, 80 to 90% of patients can be controlled with diet. Right. 10% will need insulin. And why is it important to catch these ladies early? Because if you do that, and if you give them the right diet, the right nutrition, you will be able to prevent diabetes in them later on. And you will also be able to prevent diabetes in the unborn offspring. Right.
Because you're telling us about gestational diabetes. So women who have gestational diabetes during their pregnancy, are they more likely to develop type 2 diabetes at a later stage in their lives?
Yes, they are. And that is the main reason why we treat them early. And we have to keep them under follow-up as well. So if you know anybody who has had gestational diabetes, that is right, diabetes during pregnancy, 80% chances are she would have been treated with diet.
Right.
and then she would have forgotten about it. But that is where we make a mistake. So after she has delivered the baby, and then annually thereafter, she must keep on getting herself checked for diabetes, and she should always follow a healthy diet so that she can prevent type 2 diabetes and then prevent its complications.
Right. Dr. Kalra, you explained the difference between type 1 and type 2 diabetes. And you said that type 1 and pancreatic diabetes are rarer in comparison to type 2 diabetes. Now, when a patient gets tested in the lab, the sugar levels, the fasting and the postprandial levels, both of them are high. So at that time, what kind of tests do doctors advise to distinguish between these different types of diabetes?
In the vast majority, it is easy to pick up actually clinically. You talk to the patient, listen to the patient rather, that would be more accurate. You listen to the patient and examine him or her. And like I said, in 90% of patients, it will be type 2.
Right.
In most patients with type 1, the clinical presentation is such that it is easy to diagnose, it is easy to recognize. The simplest test would be something called a urine ketone, a 10 rupee test. You get your ketones done, so you give any urine sample. If ketones are positive, along with a high glucose value, that is usually a type 1 diabetes scenario, usually, but not always. If ketones are positive, we will have to treat with insulin. If ketones are negative, we can manage with tablets. This is a very simplistic heuristic, but it's the way we work.
Right.
Another thing is that apart from type 1 and type 2, there is something known as type 1.5 diabetes. And this is where we get confused. And then we need more investigations. So let me speak about them. What is type 1.5 diabetes? In some people, it presents as type 1 with a very explosive onset. Patients are very sick. But within 2 or 3 weeks, you see that the patient has become better. And now the patient is responding to tablets. So finally, you end up treating like type 2. This is also known as Flatbush diabetes. It's called Flatbush because that is the name of the road, the avenue in New York where this was first diagnosed in Black Americans. This is quite common in Northwest India. There is another type of type 1.5 diabetes, which is also common in Northwest India. Here, the patient presents like a type 2 diabetes patient, keeps on getting treatment from you. After a few months or a few years, you realize that the patient is not responding to therapy. The patient is not complaining also, but the glucose levels are high all the time. And then when you investigate, we'll talk about that, then you realize the patient actually had type 1 diabetes all the time to begin with. This is also known as LADA, L-A-D-A, late onset autoimmune diabetes of adults. So it is a late onset type 1 diabetes occurring in adults. Some of the tests. Yeah. Carry on.
No, sorry to interrupt you, but you said that doctors, after clinical examination, they are able to make out, they don't have to advise patients to undergo specialized tests because clinical examination and listening to the patients, they are able to distinguish whether it is type 1 or type 2. Dr. Kalra, can you tell us what exactly is like the classic presentation of type 1 diabetes? What does the patient, a young adolescent, teenager patient, what kind of symptoms does he or she present with?
So before I do that, let me just say that in most patients, we are able to diagnose. In some patients, we are not able to diagnose the type of diabetes on the first visit. But that doesn't mean we are not able to treat. We begin treating according to the symptoms, according to the glucose levels, and according to whether ketones are present or not. And we tell the patient that maybe we are not able to diagnose the type of diabetes today, but as we follow you up, we will understand how this type 1.5 diabetes is evolving, which way it goes, and we'll be able to pick up the diagnosis later. Sometimes we have to do something called a C-peptide. C-peptide is a blood test which tells us how much insulin is being produced from the pancreas. In type 1 diabetes, it will be virtually zero. In type 2 diabetes, it will be high. We can also get antibodies done. These are expensive tests. Antibodies will be positive in type 1 diabetes, negative in type 2. But like you said, usually it's easy to diagnose based upon the symptoms. And a type 1 child will come in with explosive symptoms. Lots of thirst, lots of going to the bathroom, lots of hunger, eating everything there is at home and still not gaining weight, losing weight in spite of eating extra food. A sallow look, the child will not smile. You will have to force the child to smile.
Okay.
The child also may have infections. It can be a skin infection, an ear infection, eye flu. The commonest that we see here in India is urinary tract infections,
Okay.
burning in the urine, or genital tract infections,
Okay.
infections around the private parts. This is what we
Right.
see most often. And it can be tuberculosis or a foot infection. So this
Okay.
is how the patient responds. But
Right.
the beauty is that the moment you give insulin, within an hour, you see a smile on that child's face.
Okay.
Yeah. So it acts like magic. It's like you have a thirsty crow and you give food, you give a drink to that thirsty crow.
Right.
Which reminds me of some of my friends in New Delhi who are actually thirsty crow.
Right.
So they feel
So
happy. Yeah.
that's really heartening to know what you say, that type 1 diabetes, which is generally seen in teenagers or
Yeah.
adolescents, and frequent urination, frequent thirst, and a lot of infections, could be various kinds of infections of the genital tract, or tuberculosis, or maybe of the skin. So these are the things that parents should be vigilant about.
Aware of.
And
Yes.
so type 1 diabetes, is its prognosis, is its outcome, and is that a kind of harsher prognosis? Can they live a normal life? I mean, yes, it responds to insulin. You say that it's like the patient is like a thirsty crow and you give them insulin. So such a person is going to be dependent on insulin all their life?
So it's a subtle play with the words, and like you're a specialist in English literature, in prose and poetry both. Type 1 diabetes will not harm you as long as you control it.
Okay.
It is uncontrolled type 1 diabetes which has a bad prognosis, which has a harsh prognosis. So we
Right.
should differentiate between treated and untreated,
Right.
controlled and uncontrolled. The second thing is regarding dependency. Let's view it like my spectacles. Now, what is the definition of health for me? For me, the definition of health is a state of sustainable physical, emotional, social, professional well being.
Right.
With my spectacles, I'm able to do that. And I've
Right.
been living with spectacles now for upwards of 45 years.
Right.
They're my best friend.
Right.
They keep me healthy. I do not feel dependent upon them.
Right.
Right. But supposing my mom 45 years ago was uh, in a state where maybe she began viewing spectacles as a hated intruder
Right.
into my life.
Right.
She prevented me from taking spectacles.
Right.
I would have still gone to school, but I doubt if I would have passed any class. I would
Right.
have
Right. Right.
barely made it through school and college, and I might have the girl sitting on the bench next to me might have helped me if she was in a kind mood. I would
Right.
have passed the exam somehow or the other, but certainly I would not have grasped the intricacies and the nuances of Shakespeare and
Right.
Byron. That I would not have been able to do without
Right.
specs. So
Understand.
that is how insulin is. It actually helps you live a healthy life. It
Right.
helps you live a healthy, sustainable life.
Right.
Hmm.
And this is just out of curiosity. Does type 1 diabetes kind of mutate into type 2, or is it? I mean, this
That
is
is
just
the
a
type,
layperson.
yeah, that is the type 1.5 that we have.
Okay. That.
So type 1 diabetes, sometimes you can have what is called a honeymoon period.
Okay.
So where the pancreas begins to work slightly, and the
Okay.
honeymoon period can last for some time.
Okay.
That is fairly frequent in practice. The dose requirement goes down. But type 1.5 diabetes, like I said, is quite common.
Right.
Uh, there are two types of type 1.5, which we already mentioned. So
Right.
now this is speaking from a Northwest Indian perspective.
Right.
If you have a normal Indian phenotype, a normal Indian build,
Right.
uh, dark complexion or normal complexion for your ethnic group,
Right.
hirsute body, that means normal
Hair
facial
cover.
hair
Right.
as per your ethnic group, whether you are male or female. Uh, Other symptoms of metabolic syndrome, like high blood pressure, obesity, lipids,
Right.
fatty liver, then the chances of the flatbush diabetes are more.
Right.
Initially, it may be type 1, but it can get corrected to type 2. If, however, it's a it's a different phenotype, beautiful women, handsome men, fairer than their ethnic group's norm, light-colored hair, light-colored eyes, beautiful eyes, and fair skin. Maybe thyroid disease is also there. Maybe some skin disease is also there. This goes in favor of LADA. in favor of autoimmune. So initially they may be treated as type 2, but finally they will end up being type 1.
Dr. Kalra, in your answer, you just now you mentioned metabolic syndrome. So could you kind of, because we hear this term, lay people hear this term, I think doctors use it, but we don't really understand what a metabolic syndrome is. So if you could kind of explain that for our viewers.
Yeah, thanks for raising this. This is really important. So what is a syndrome? A syndrome is a group of symptoms, signs, and laboratory abnormalities. Symptom means something that you go to the doctor with. So my symptom may be I have a cough, I have a cold, I have a runny nose.
Right.
Sign is something that the doctor elicits. So your doctor may say, open your mouth and say, you have tonsils. So that is a sign. He has seen enlarged tonsils. And lab abnormalities is the test that you get done. So let us paraphrase this again. First, we said symptoms, signs, and lab anomalies. Now we are going to say complaints and concerns. So as a patient, my complaint might be that I'm gaining weight. My concern may be that I'm worried about heart disease in the future.
Right.
My concern also may just be that I'm not able to fit into my favorite shirt anymore. Or the person whom I want to be friends with, she's saying no to me because I'm overweight. So that is a major concern for me. So these concerns and complaints put together make a syndrome.
Right.
Metabolic syndrome means related to the metabolism, the running of our body. And if you remember, we use this acronym DHOL from Hindi.
Right. Right.
That is actually an acronym for metabolic syndrome. D for diabetes, H for high blood pressure, O for overweight or obesity, L for lipids, that is cholesterol, and L for liver, fatty liver. Any permutation combination of these is classified as metabolic syndrome.
So even if you have two of these, suppose a person is obese and diabetic, they would be classified as having metabolic syndrome.
There are different definitions actually from different bodies. In general, you need 3 at least. But overall, you will find that apart from the DHOL that we mentioned, there are other things also like high uric acid, polycystic ovary syndrome, obstructive sleep apnea.
Right.
So all these actually interplay with each other.
Right.
And the approach to treatment is the same.
Right.
And the best part, Dr. Diwan, is that the approach is again in our hands and our feet. The approach is lifestyle modification for all of them. But that is something that most of us are happy just paying lip service to instead of actually following.
Right. I think our post-globalization, particularly because you mentioned historical reasons, the storage of fat around the abdomen because of our history of famines. I think post-globalization, I think increasing affluence, increasing prosperity in India post-90s globalization, and consumption of a lot of processed foods, I think has also led to a kind of, those kind of change lifestyles. I come to my next question. You use the term a combination of diabesity. I think a lot of Indians are in that category. They can be, classified by using this term. It seems to be a very appropriate term to describe. So could you please, speak more about that?
So diabesity is also a subtype of metabolic syndrome. So if you see, there is diabetes and there is obesity. Right. And usually you will have something else or the other also along with that. High blood pressure, cholesterol. If you don't have it now, it will develop. It will come up in the next couple of years. With diabesity, what is our main focus? The first is to reduce weight. Right. The second is to reduce glucose. Why do we want to do both of them? Our long-term aim is to reduce the risk of heart disease. Exactly. Or kidney disease. That is our long-term aim. Right. If we are able to reduce heart disease and kidney disease, we will be able to reduce overall healthcare costs, right, and we will be able to increase longevity. Right. So our final aim is a happy and healthy and long life. Right. When you have diabetes, there are some drugs which we would want to avoid. These are drugs which do control glucose, but might end up increasing weight. Okay. There are other drugs that we prefer. Examples are metformin, a class of drugs known as SGLT2 inhibitors, which act by increasing the excretion of glucose through the urine. Right. Another class of drugs, which earlier were only injectable, but now we have oral forms also in India, we have tablets, that is called GLP-1 receptor agonists. So these are the drugs that we prefer: metformin, acarbose, SGLT2 inhibitors, GLP-1RA. We use these. We also focus more on lifestyle modification, which would mean a balanced diet and also exercise.
Yeah.
And, and along with that, we don't forget to give other drugs which prevent heart disease, like drugs which reduce cholesterol, for example. We use these so that in the long run, there is no heart disease.
So what I've understood from our conversation is that that the drugs which are chosen to treat type 2 diabetes also, the combination of those drugs, I think it varies from person to person. And, we Indians tend to compare our prescriptions, and what, I'm diabetic and you are diabetic, and what has your doctor given you? And we tend to think that prescriptions can be compared. But what I've understood is that it's very individualized. I mean, it is the person's comorbidities and various other factors that you've mentioned. They are, they are the ones which help the doctors decide which medicines are going to suit patient. I'd just like to ask you, I mean, you hear so many claims in newspapers, magazines, all over the net. For instance, on YouTube, anybody going through YouTube, reverse diabetes in 5 days, cure diabetes in 10 days, these kind of exaggerated claims, which one finds all over. So is there any kind of authenticity or credibility to these claims, or are they all dubious?
Almost all of them are dubious. It is not possible to cure diabetes unless you're talking about gestational diabetes. That will get cured when the lady delivers. But even then, you have to follow up later because she might get type 2 diabetes later. It is also not possible to reverse anything in life. Earlier, Dr. Divan, we used to speak of Newtonian physics. Newtonian physics means every action has an equal and opposite reaction. And I read a very interesting article about 120 years old, where somebody stood up and said that now we have discovered everything there is to discover about physics. Now there is no need to do a PhD in physics anymore. But that gentleman was mistaken, because then quantum physics came in. Quantum physics says, in very simple words, energy is equal to matter. You may be able to see some forms of energy. You may be able to feel some forms of energy, but not all. Some things will be tangible, others will be intangible. So it's a very complex play. So when there is quantum physics involved in physics, why should we not assume that there is quantum diabetology also involved in diabetes? And so if someone says I can reverse diabetes, that is a very tubular, a very simplistic, a very Newtonian kind of an approach, which is not going to work. There is a correct word, that is remission. So it is possible to achieve remission of type 2 diabetes, not of type 1 or pancreatic. And we have a formula, it's called ABCDE. ABCD was coined by a scientist called Lee, LEE. ABCDE is an Indian formula. This tells us the patients in which there is a higher probability of remission. So we must try. A is for age, if it is a young adult. B is for body weight, if the body weight is more and the patient is willing to bring it down, willing to and able to bring it down, to lose weight. C is for C-peptide. We alluded to that earlier. C-peptide is normal. It means insulin is normal, so there is a chance. D is for duration of diabetes. If the duration of diabetes is short, the patient has recently been found to have diabetes, there is no permanent damage to the pancreas or to the rest of the body, so we can think of remission. Age, body weight, C-peptide, and duration. But the most important is E. E is for energy, enthusiasm, education, engagement with the healthcare team. So if you are educated, energetic, enthusiastic, you are willing to do what it takes, you are willing to engage with the healthcare team, then there is a chance of remission. So yes, in people who have been recently diagnosed to have diabetes at a young age as adults, and it's type 2 diabetes, we can think of remission.
So as Dr. Kalra, you've explained so well, using these acronyms, which will stay in the consciousness of patients, that you can use acronyms to remember things. And as you said, that in type 2 diabetes, patients, if they are proactive and they take a proactive approach to keeping their body weight under check, and leading a healthy lifestyle and eating a healthy diet, then they can go into remission. But does that mean that they can be weaned off the medication, or will they have to continue on the medication lifelong?
Remission means, when we define remission, we say that we have taken the patient off medication. Okay. So it is possible. But like I said, it occurs in young adults and those who come to us early. Right. But even if you are not able to wean yourself off medication, right, even if that is not possible, if you follow a healthy lifestyle, certainly you can reduce the pill burden. You can reduce the number of injections or the number of tablets that you are taking. The unfortunate thing, Dr. Devan, is that there are unscrupulous people in the world. Right. Just for financial gain or for fame, they extend this to type 1 diabetes. Okay. So if you allow, let me just share examples. There are people, well-known people in the country, who advertise that they can cure type 1 diabetes. Right. They say that insulin can be stopped in children who live with diabetes. Right. What they do is they admit these hapless children, and the children have no power over their own body. Right. They sort of take advantage of the gullible parents, right, admit the children, and put them on a starvation diet. Right. This is something that used to be done more than 100 years ago, when insulin had not been invented, not been discovered. Right. So they starve these patients. Then they very proudly say that I have stopped insulin. But this is not sustainable. Right. And what I would like to say to those people who are in such powerful and such strong positions, you can do whatever you want with your body, but please do not mess around with our children. They are the future of our country. Right. Now, supposing I'm growing wheat or I'm growing rice. If I do not give water to my plant, if I do not give fertilizer to my plant, if I do not give sunlight, tender loving care, the plant is not going to grow. It will remain stunted. Am I happy with that? Right. That is a question to them. And the second thing is, if then someone comes and says that I am using less fertilizer here because the plant is stunted. Right. Is that a matter of happiness that I used less fertilizer? Or is it a matter of sorrow that I could not get the potential yield? Right. This is what is being done with children with type 1 diabetes in the name of reversal, and it is just being done for financial gains. And that is harmful. It is very hurtful as well, Dr. Devan. This is a very alarming thing that you've told us, because one, as I said, one reads about these claims and one hears about these claims about the reversal of diabetes, but you've explained to us how unscrupulous or unethical elements they may just be quacks, they may not even be qualified medical professionals who resort to these kind of practices. So parents, I would like to just kind of send out a message here to my viewers, that parents of children or young children who are diagnosed with type 1 diabetes, please do not fall prey to these kind of claims. Let us not take these claims seriously without kind of going to a qualified medical professional, because such patients of type 1 diabetes may have to be insulin dependent all their lives. Is that so? Right. Yes. And it's not insulin dependent. It's just that they are living with insulin. Right. The same way that I'm living with my spectacles. Glasses. And I'm living happily ever after. Right. If someone is misusing the name of Ayurveda or any other medical stream, that is not the fault of Ayurveda. Right. Ayurveda is a very well-developed subject, which is based upon science. But no science is infinite. My subject is also not infinite. Right. Every year there is a new Nobel Prize winner in literature, which means there are new things to discover, new things to do. Right now we classify as prose and poetry, but does that mean that there can be no form of literature which is separate from this? You can always create a new form. Right. So if a particular field of medicine was not able to create a glucometer in 5,000 years, was not able to measure and diagnose diabetes, how can they claim to treat it? When you cannot measure, how can you treat? Right. So parents should look at that as well. What is the scientific background or strength that a particular person is coming with it? Right. And it's not a question of pitting one branch of medicine. It's not
allopathy versus homeopathy and Ayurveda.
Not at
It's
all.
not
All
that.
are equally good.
Right.
All
Right.
are equally good. All are equally respected. It is the
Right.
people who are misusing the name of Ayurveda.
Right. Right.
They misuse the name of Ayurveda because it sells.
Right.
But if you were to go to the Ayurveda textbook would never tell you to harm your child or harm your patient. And when they describe treatment for diabetes, they are describing it for type 2 diabetes. They actually describe diabetes so well in Charak Samhita.
Right. I think 500 BC, Charak had talked about Madhume, as you mentioned him. Dr. Kalra, since diabetes is a vast topic, and I don't think we can discuss all the aspects of the disease in one session, I think we'll have to kind of stop here for today. And I'd like to conclude today's episode by referring to my viewers and telling them that type 1, Dr. Kalra has explained so well the mechanism of diabetes, the different types of diabetes, the management options, the different kinds of regimes of medication, which have to be individually suited for different kinds of patients. We have dealt with testing and diagnosis and differentiation between different types of diabetes. I think in the next session, viewers, we can discuss treatment, management, and prevention, the three very important areas. So I'd like to again reassure the viewers that let us not despair. However grim or bleak the situation may look, if we make these lifestyle changes, I think the battle of diabetes can be won. So thank you, Dr. Kalra. Thank you, viewers. Stay informed, stay healthy.
Thank you.